Hello, I'm Matthew Cooper, Director of Kidney and Pancreas Transplantation at MedStar Georgetown Transplant Institute and Professor of Surgery at Georgetown University School of Medicine in Washington, D.C. Thank you for your interest in learning more about FCR001, an investigational cell therapy that is being developed by Talaris Therapeutics. FCR001 is designed to induce immune tolerance, and it is being investigated for use in conjunction with living donor kidney transplant. Today, we'll be reviewing some of the living donor kidney transplant clinical trial data. FCR001 was evaluated in an open-label, single-arm Phase 2 study, which included 36 donor-recipient pairs at Northwestern University Medical Center and 1 at Duke University Medical Center. The primary endpoint was durable tolerance with significant reduction or discontinuation of immunosuppression at 12 months. Donor-recipient pairs were adults between the ages of 18 and 65 years who met eligibility criteria. All levels of HLA mismatching between donor and recipients were allowed. Prior to transplant, donors underwent stem cell mobilization with GCSF, and mobilized cells were collected and processed to produce FCR001. Prior to transplant, recipients also underwent mobilization and apheresis, and stem cells were cryopreserved as a standard safety measure. Recipients underwent non-myeloablative conditioning with fludarabine on days -4 to -2 and received cyclophosphamide plus mesna on day -3. Dialysis was performed after each conditioning treatment. On day -1, recipients underwent low-dose total body irradiation. Kidney transplant occurred on day 0, followed by stem cell transplant via FCR001 infusion on day 1. On post-transplant day 3, recipients were given an additional dose of cyclophosphamide plus mesna as prophylaxis against GVHD, which is standard of care in allogeneic hematopoietic stem cell transplant. Recipients initiated immunosuppression with tacrolimus and mycophenolate mofetil, or MMF, 3 days prior to kidney transplant. Patients who had stable donor chimerism, defined as at least 50% donor T cells, and had stable graft function with no biopsy-proven acute rejection, or GVHD, could discontinue MMF at the end of 6 months post-transplant and could start weaning tacrolimus at the beginning of month 9 with complete discontinuation at the end of month 12. Recipients are currently being followed for a total of 15 years. As of March 1, 2022, 33 recipients had at least 36 months of follow-up, and 29 had at least 60 months of follow-up. Exposure to FCR001 was approximately 280 patient years. Now let's get to the outcomes seen in the Phase 2 trial so far. 27 of 37 patients in the trial achieved durable chimerism. 26 of these were able to discontinue immunosuppression with no biopsy-proven acute rejection or donor-specific antibody and with stable renal function that has persisted over time. One of the 27 patients who achieved durable chimerism, however, developed GVHD and subsequently died, which I will discuss in greater detail later. Because of the development of GVHD, this patient was unable to withdraw from immunosuppression. As of March 1, 2022, the median follow-up time was more than 6 years. 26 patients had stable chimerism and remained off immunosuppression. 8 patients were transiently chimeric and were on immunosuppression. Most of these lost donor chimerism within 2 to 5 months after transplant. Factors that were suspected to have contributed to transient chimerism included low number of donor cells, high panel reactive antibody, no post-transplant cyclophosphamide, C. difficile infection, cytomegalovirus or CMV reactivation, an older donor, and hemolytic anemia. Among transiently chimeric patients who remained on immunosuppression, 5 experienced rejection, 3 had graft losses, and 1 died. 2 patients who failed to engraft and did not achieve chimerism remain on immunosuppression. Failure to achieve chimerism was suspected to be associated with high panel reactive antibody in 1 patient and an underlying bone marrow disorder, large platelet syndrome, in the other patient. Now let's take a closer look at the 26 durably chimeric patients who discontinued immunosuppression. At the March 1, 2022 data cutoff, 5 of 26 were immunosuppression-free for more than 10 years. Interestingly, when the role of HLA matching was examined in these 26 recipients, no correlation was observed between the degree of HLA match and the achievement of durable chimerism plus discontinuation of immunosuppression, or with the incidence of GVHD or other safety outcomes. And 19 patients, or 73%, matched with their donor at 3 or fewer HLA loci out of 6. Bidirectional recipient and donor matching was also evaluated for 32 pairs from the Phase 2 study, including 25 recipients who were off immunosuppression. High-resolution allele typing for HLA-A, B, C, DRB1, DQB1, and DPB1 was performed for all but 3 pairs that only had enough DNA to type 10 of 12 alleles. All recipients had reached at least 4.5 years of follow-up, with a median of more than 6 years and a maximum of more than 12 years of follow-up. Once again, there was no correlation between the degree of HLA match and durable chimerism, GVHD, or other safety outcomes. Now let's take a look at donor chimerism. The presence of donor chimerism during the first year after FCR001 facilitated transplant was identified as a possible predictor of durable immune tolerance. For the purposes of this study, persistent donor chimerism of at least 50% donor T cells at 3 and 6 months was used to guide tapering of immunosuppression. As you can see here, mean donor chimerism in patients who were off chronic immunosuppression at 1 year was about 90% from month 2 onward, meaning that about 90% of the recipient's T cells were donor-derived. 26 of 29, or 90%, of patients who were chimeric at month 3, and 26 of 27, or 96%, of patients who were chimeric at month 6 discontinued immunosuppression at month 12. And all 26 of these patients remained off immunosuppression for a median of more than 6 years and a maximum of more than 12 years of follow-up. Now let's take a look at some additional analyses that evaluated the impact of FCR001 on post-transplant health. The Phase 2 study did not include a control arm, so a retrospective analysis of matched controls was performed comparing renal function and cardiovascular medication use in FCR001 recipients with a comparable standard of care population. The standard of care population consisted of 132 patients who underwent standard living donor kidney transplant at Northwestern University Medical Center between 2009 and 2012, who met FCR001 Phase 2 eligibility criteria and were on lifelong immunosuppression. Retrospective analysis of estimated glomerular filtration rate, or eGFR, showed preserved renal function for up to 5 years in the FCR001 Phase 2 group, while renal function declined in the standard of care group over time. For patients who discontinued immunosuppression, mean eGFR was 66.1 mils per minute per 1.73 meters squared at 5 years. Mean renal function calculation excludes graft losses occurring prior to a given time point. Because of the retrospective nature of this analysis, 1 month and 5-year data were not available for the standard of care group. In the same retrospective analysis, rates of hypertension medication use were 18% and 83% for the FCR001 and standard of care groups respectively at 4 years post-transplant. And rates of hyperlipidemia medication use were 9% and 43% for the FCR001 and standard of care groups respectively. Another area of interest in kidney transplant is recurrence of autoimmune kidney disease, which can contribute to graft loss. Of the 7 patients who were durably chimeric and who were indicated for transplant due to autoimmune kidney disease, none have experienced recurrence at median follow-up of more than 6 years. However, among non-chimeric or transient chimeric patients, IgA nephropathy or membranous glomerulonephritis recurred in 1 patient each. Notably, recurrence rates of these autoimmune kidney diseases in the general kidney transplant population ranges from 8% to 55%. These findings in the Phase 2 study are interesting, but will need to be evaluated in a larger cohort. Other important immunological questions are, what does the immune system look like after non-myeloablative conditioning and facilitated allogeneic stem cell transplant with FCR001, and does the recipient reconstitute an active immune system? To address this, overall leukocyte and T cell subpopulation recovery were evaluated in the first 12 patients in the Phase 2 study who maintained chimerism. Here we see that the counts for CD3 positive T cells, CD19 positive B cells, CD56 positive natural killer cells, and CD14 positive monocytes decreased after conditioning and transplant, but started to recover within 3 months. And looking more closely at T cell subpopulations, we see that CD8 positive cells recovered more quickly than CD4 positive cells, and that memory phenotypes of both CD4 positive and CD8 positive T cells were dominant over naive T cells. Most importantly, these results indicate a full immune reconstitution following FCR001 therapy. Now that we have reviewed some of the efficacy outcomes in the Phase 2 trial, let's take a closer look at the safety findings. As previously mentioned, 3 graft losses occurred in the Phase 2 trial. In all cases, immunosuppression was markedly decreased because of severe infections, which resulted in acute rejection in 2 patients and ultimately graft loss. 1 graft loss occurred in a patient who had graft thrombosis during a viral sepsis episode. This patient was hypotensive, hemodynamically unstable, and required continuous veno-venous hemofiltration. The 2nd graft loss was in a patient who experienced sepsis that did not respond to antibiotics. Complete interruption of immunosuppression was required to address the infection. The 3rd instance of graft loss was in a patient who lost donor chimerism 4 months after transplant, secondary to CMV reactivation. The patient continued immunosuppression and was switched to belatacept at month 26 because of calcineurin inhibitor nephrotoxicity. Immunosuppression was later reduced because of recurrent CMV, BK viremia, and a Pseudomonas infection, and the patient subsequently experienced acute cellular rejection and chronic antibody-mediated rejection. Dialysis was initiated after decline in renal function was observed. Biopsy-proven acute rejection occurred in 7 patients, 5 of whom were transiently chimeric and 2 who were never chimeric. 6 of these patients were maintained on lower than normal levels of immunosuppression, and 4 were maintained on monotherapy with tacrolimus or sirolimus. No acute rejection or de novo donor-specific antibody occurred in patients off immunosuppression. FCR001 infusions have been well tolerated with no infusion-related reactions. Most adverse events occurred during the first 12 months post-transplant while patients were on conventional immunosuppression. The most common adverse events, occurring in more than 20% of patients, were diarrhea, BK viruria and viremia, fever, cough, and nausea. The most common severe adverse events, occurring in more than 5% of patients, were fever, deep vein thrombosis, diarrhea, pneumonia, and febrile neutropenia. The most common infections were BK viruria and viremia, nasopharyngitis, cellulitis, upper respiratory tract infection, and urinary tract infection. GVHD is a notable and potentially life-threatening adverse event associated with allogeneic stem cell transplant. In the FCR001 Phase 2 study, acute GVHD occurred in 2 durably chimeric patients. 1 patient with grade 2 GVHD was treated with steroids and is now off immunosuppression but has chronic GVHD with ocular and musculoskeletal symptoms. 1 patient with grade 3 GVHD presented late with diarrhea and had a protracted course of GVHD that was complicated by tissue-invasive CMV colitis and infection. At approximately 11 months post-transplant, the patient's condition deteriorated after developing a pulmonary process of undetermined etiology. He ultimately developed septic shock, which progressed to multi-organ failure and death, which is the worst possible outcome of GVHD. Overall, patients who received FCR001 and achieved durable chimerism had a slightly lower 5-year survival rate compared with living donor kidney transplant recipients in the United Network for Organ Sharing database. However, the small sample size in the Phase 2 trial makes comparison difficult and does not allow statistical comparison with national data. 3 deaths occurred in durably chimeric patients at 11 months, 3.5 years, and 4.5 years. The death at 11 months was in the previously mentioned patient with grade 3 GVHD. The death at 3.5 years was from pneumococcal sepsis in a subject traveling abroad who was non-adherent and was not revaccinated per stem cell protocol. The death at 4.5 years was from a lung cancer and a heavy smoker. 1 death occurred in a transiently chimeric patient 4.5 years after transplant because of candidiasis and respiratory failure, secondary to septic shock and aspiration pneumonia. Of course, donor safety is also a key consideration as part of this therapy. In the Phase 2 study, adverse events reported in donors were mild to moderate, and no serious adverse events were reported. Donor adverse events were consistent with standard stem cell mobilization and GCSF. headache, fatigue, musculoskeletal pain, and nausea. Adverse events occurred around the time of GCSF administration for stem cell mobilization and apheresis. As I touched upon earlier, follow-up for recipients in the Phase 2 study is ongoing and will continue through 15 years post-transplant. Based on outcomes in this study, Talaris Therapeutics is now enrolling patients in a Phase 3 trial, Freedom-1, that will provide additional safety and efficacy data in living donor kidney transplant. To learn more about Freedom-1, please visit the study site at freedom1study.com or the NIH clinical trials site. Thank you for your time and your commitment to kidney transplant.